Bismillah ar-Rahman ar-Rahim. Valvular heart disease. First part. This part will discuss the following: the concept of stenosis and regurgitation of the valve, an example of a congenital heart valve disease, and then an example of an acquired heart valve disease. Normally, the heart has 4 chambers and 4 valves that separate the different heart chambers. The direction of blood flow through those chambers depends on their location. Starting from the right side of the heart, the venous blood that reaches the right atrium through the superior vena cava and the inferior vena cava will then go into the right ventricle through the tricuspid valve. From there, the blood from the right ventricle will go to and reach the lung through the pulmonary valve that will give the blood into the pulmonary arteries. On the left side of the heart, the highly oxygenated or systemic or arterial blood that will be coming from the lung towards the left atrium will then travel through the mitral valve into the left ventricle. And from there, during systole, the blood will be pumped out of the left ventricle through the aortic valve and then into the aorta. For more details about the blood flow through the heart and the different heart chambers and the heart valves, please click on the following link. First, we have the concept of valve stenosis versus valve regurgitation. The word valve stenosis means that the valve does not open appropriately. This is usually due to a chronic process like inflammation and scarring of the affected valve. On the other hand, valve regurgitation refers to a valve that does not close properly. Other terms that describe valve regurgitation include valve incompetence and valve insufficiency. Valve regurgitation can be developing either due to valve cusp abnormality or due to abnormalities that affect the supporting structures of the valve. These include the mitral annulus, the tendinous cords, and the papillary muscles. Valve regurgitation can be either an acute or a chronic process. Causes of acute valve regurgitation, for example, we have chordal rupture. A cause for cardiac valve regurgitation as a chronic one, for example, we have scarring. Clinical signs of valve disease include the following. First of all, we have murmurs. Murmurs are abnormal heart sounds. So if you look at this picture here, this line represents the normal heart beat. So as you can see, you can recognize there is some kind of pattern. There are 2 sounds that are normally present and heard by a stethoscope. These are called S1 and S2. While if you look up at the heart murmur here, there's some abnormally added sounds, either during systole or during diastole. Now, when the heart murmur is so loud, it can be sometimes even palpated during physical examination of the chest. At this point, it is called thrill. Now, in addition to murmurs and thrills, the presence of certain valve diseases can lead to specific clinical signs according to the specifically involved valve. So as you can see in this example, this is not for memorization, it's only for you to know that there are different types and sounds that can be heard as murmurs according to the affected valve. Valvular disease can be either congenital or acquired. The most common congenital valve lesion is called bicuspid aortic valve, while the most important cause of acquired valve disease is rheumatic fever. We will be discussing briefly these 2 conditions in this lecture. Bicuspid aortic valve refers to the presence of abnormally two cusps instead of the normal three in the semilunar aortic valve. This condition affects 1 to 2% of all live births. It can be either isolated abnormality or associated with other congenital anomalies. During early life, this condition might be completely asymptomatic, but later on, during the age or at the age of 50, there will be some early and progressive degenerative calcification of the aortic valve. This degenerative calcification of the aortic valve and the associated fibrosis will lead to aortic stenosis. So, whenever aortic valve stenosis develops, the consequences on the heart would be that the heart is not ejecting enough blood through the aorta from the left ventricle. So, with time, this will lead to increased load on the left ventricle, and then the left ventricle would develop left ventricular hypertrophy. Also, the cardiac output will be reduced significantly. And these are the major consequences of aortic valve stenosis. Moving into acquired valve diseases, we will be talking about one example in this lecture and some other examples maybe in next lecture. The mitral valve is considered to be the most common target of acquired valve diseases. Most common cause of acquired valve disease is post-inflammatory scarring due to rheumatic fever, which may be affecting up to 2/3 of all cases. Rheumatic fever, or rheumatic carditis, or rheumatic valve disease, they all mean the same thing. This disease is an immune-mediated inflammatory condition that follows infection caused by group A beta-hemolytic streptococci. The incidence of this condition has dropped in Western world thanks to the improved socio-economic status, the rapid diagnosis and treatment of streptococcal pharyngitis by antibiotics. This problem, however, is still an important public health problem in developing countries. So please pay attention that here we are talking about bacterial pharyngitis that is caused by group A beta-hemolytic streptococci. This kind of pharyngitis requires antibiotic therapy, especially penicillin injection. This problem has been almost overcome in the Western world, but it's still a major health problem in some developing countries. So this patient, which is usually a child affected by bacterial pharyngitis, if he gets the proper or appropriate antibiotic therapy, this will save him from the risk of rheumatic fever. If this child is not well treated or appropriately treated with antibiotic injections, he might be at risk of development of this condition, rheumatic fever. So what happens in rheumatic fever? There's some kind of a hypersensitivity reaction due to the presence of autoantibodies against group A streptococcal antigens. These autoantibodies will cross-react with certain host antigens. Those host antigens are distributed in several organs, and these include the heart, the brain, the joints, and the skin. So, the patient, which is usually a child, developing a bacterial pharyngitis in most of the cases, and sometimes bacterial skin wound infection, will develop this immunologic reaction sometime or maybe a couple of weeks or 3 weeks following the acute infection. This reaction is immunologic. We mean by that it's caused by the immune system and not by the bacteria itself. The immune system, when it will encounter the infection, will form antibodies against group A streptococcal antigens. Some patients, a small percentage of them, these antibodies will be cross-reactive with host antigens. The host antigens, يعني self-antigens, are found in the heart, the joints, the skin, and the brain. So the manifestations of rheumatic fever may be seen a few weeks following pharyngitis or skin infection caused by group A beta hemolytic streptococci. The major organs that are involved with rheumatic fever are the heart, joints, skin, and the brain. This condition has two major phases, an acute phase and a chronic phase. The acute phase is characterized by fever, arthritis, central nervous system symptoms, and carditis. The chronic phase is heralded by cardiac valve disease. In the acute phase, the patient, which is usually a child, will develop fever, migratory polyarthritis, and carditis. Other manifestations include skin rashes and certain central nervous system manifestations. The word carditis here is detected clinically by the presence of arrhythmias, signs and symptoms of myocarditis, cardiac dilation, and functional mitral insufficiency and possibly congestive heart failure. For the diagnosis of this condition, we need a proof or an evidence of a previous streptococcal infection, and this can be found using the serum titers for some streptococcal antigens like streptolysin O or DNase. A high serum titers of those streptococcal antigens is required for confirmation of this diagnosis. Culture for streptococci is, however, negative at the time of symptom onset because the infection itself would have been spontaneously resolved or treated during this period of time. The clinical manifestations of the acute phase of rheumatic fever had been lumped together and called Jones criteria. The word Jones here is coming from the first letter of the main clinical signs and symptoms. Jones. So the letter J is coming from joints or arthritis. The O here represents carditis. N is for nodules, subcutaneous nodules. E is for erythema marginatum, which is the kind of skin rash that is characteristic of this condition. And the S stands for Sydenham's chorea, which is abnormal twitching, jerking muscle movement that can follow this kind of disease. Morphology of the carditis during the acute phase. The major points you should remember here that acute rheumatic fever will lead to the formation of valve vegetations, and as you can recall from our first lecture, valve vegetations means thrombi overlying the heart valves. So here the inflammation will reach the endocardium that covers the heart valves, and it will lead to formation of valve vegetations. Now, inside the affected parts of the heart, which can involve the endocardium, the myocardium, and the heart valves, or even sometimes pericardium. In all of the affected parts of the heart that has the inflammation, there will be something very characteristic of rheumatic carditis or rheumatic fever. This characteristic thing or lesion is called Aschoff bodies. Aschoff bodies are inflammatory lesions that can be seen in the affected tissues with rheumatic fever. This lesion, Aschoff body, is pathognomonic or diagnostic of acute rheumatic fever. Inside those Aschoff bodies, if we take a cross-section and study them under microscope, we will see that these are collections of T lymphocytes, plasma cells, and some activated macrophages. The diagnosis of acute rheumatic fever depends on the presence of, as I said before, high titers of anti-streptolysin O or anti-DNase in the serum of the patient, plus certain criteria. Now, these criteria are divided into major criteria and minor criteria. The major criteria are the same as the word Jones. That's why we already discussed the Jones criteria. So Jones here refers to joint involvement by arthritis, or it looks like a heart, so this represents myocarditis or carditis. N stands for subcutaneous nodules. E is for erythema marginatum, which is the characteristic skin rash of acute rheumatic fever. And the S stands for Sydenham chorea, the CNS involvement. The minor criteria includes C-reactive protein elevation, arthralgia, fever, elevated ESR levels, possibly prolonged PR interval in the heart, the presence of rheumatism or symptoms of rheumatic fever, and leukocytosis. For a diagnosis of acute rheumatic fever, the clinician will need to have the elevated serum titers we've discussed before, plus either two major criteria or one major criterion and two minor criteria. Now, following the acute phase of rheumatic fever, and possibly years or even decades after the initial acute episode, a percentage of those patients will develop something we call the chronic phase of rheumatic fever, or rheumatic carditis. During this phase, the chronic inflammation that has been present in the valve or over the valve for many years will lead to scarring, fibrosis, and then valve stenosis. Whenever the valve stenosis is there, we will have clinical manifestations accordingly. So if the mitral valve is affected, for example, the patient will develop cardiac murmurs, congestive heart failure, arrhythmias like atrial fibrillation, and even mural thrombi inside the left atrium. The prognosis of the chronic rheumatic carditis is variable. It depends on the severity and the exact location of the affection inside the heart. The management would be either surgical repair of the affected valve or even complete replacement of the diseased valve. So during the chronic phase of rheumatic fever, there will be inflammation followed by scarring of the valve. Ash of bodies during this phase of the disease are rarely seen. Valve stenosis, which is the most important functional consequence, is the most important thing to remember whenever we talk about the chronic rheumatic carditis. All heart valves can be affected, but in order of frequency, you will see that the mitral valve is the most commonly affected one. It is followed by the aortic valve, tricuspid valve, and then the pulmonary valve is very rarely affected by rheumatic fever.